Hello, my name is Reed Tuckson, and I apologize for being unable to join you in person due to an unexpected urgency. And I appreciate this opportunity to offer a few thoughts in my allotted minutes on some perspectives that payers might have on innovative strategies to improve EHR data collection to support care quality and research initiatives. As we are all aware, payers are deeply interested in advancing value in health and medical care delivery, and they see data and analytics and applicable clinical research as essential to their goals and concerns. They remain frustrated by suboptimal clinical quality and care outcomes. They want to empower physicians and patients to make better decisions. They want to close gaps in care. They want real-world data to assess disease progression. They are concerned with waste and the increasingly unaffordable escalation in healthcare costs, cost escalations that coming out of the pandemic are no longer sustainable. They're interested in speeding up the cycle from discovery of worthwhile innovations to their evidence-based application. We're all aware of the average lag of 17 years between publication and broad adoption of important therapeutic advances. They're interested in advancing the evidence base of care delivery and best practices, such as the right person gets the right therapy at the right time. And so, whether captured doing product development activities such as clinical research trials and studies, and this is key, or as a part of the care delivery process, actionable and comprehensive data are fundamental to their objectives, especially as data enhances their ability to engage with individual patients. The business models of modern payer relationships is increasingly focused on the comprehensive needs of individuals and the evolution of personalized medicine, whether they are looked at as customers from a business perspective in this increasingly consumer-oriented industry, or as patients from a care delivery perspective. In short, they want stickiness with their patient customers over time. They want comprehensive care delivery focused on individual needs that are constantly refined based on evolving disease expression, determinate social conditions, and new therapeutic tools and knowledge, especially digital-based therapies and personalized genomic tools. In this regard, they want to better understand the implication of genetics and the individual's interaction with the environmental and social factors relevant to the individual. This personalization of care is difficult and it is costly. Payers are very focused, therefore, on controlling their capital expenditures for aggregating, maintaining, and interrogating their data systems and assets, whether for the operation of their businesses or for the purposes of research. Discipline is paramount, as is attentiveness to the competitive advantage of their data and their analytics. Ideally, an effective real-world research environment will know as many facts as possible about each individual patient. Interoperable electronic and personal health data sets integrated with laboratory values, diagnostic images, patient demographic information on behavior and preferences, claims and billing data, product and disease registries, patient-generated data from sources such as mobile devices and wireless monitors will support both, ideally, the clinical research and the care engagement objectives simultaneously. Among the most difficult challenges to this ideal scenario are concerns about the privacy of health data. One thing we know going forward from the pandemic is that trust will be very difficult to restore for significant segments of our society. The de-identified data of the past, however, won't get us where we need to go. Additionally, the trust of physicians as they engage with payers on this agenda will be especially challenging. Plans have to be concerned about the primacy of the patient-physician relationship and confidentiality. Plans have to be careful not to overreach physicians in both research and comprehensive care coordination and management engagements. Payers also have to be attentive to the patient's ownership of their own data and how those elements will be resolved. And plans have to be very careful of their other customers, the employers who hire them and who are still dominant in the purchasing equation. So going forward, HIPAA may well be ripe for revisiting in the modern context. The tensions between researchers and their partners and privacy advocates are already high and will only grow unless new ways are devised of looking at these problems. Going forward, plans have an opportunity of offering carrots to their network participants, or sticks, to enhance participation by clinicians in clinical trial participation, or certainly in data access and provision across the continuum of care. Going forward, payers might themselves be offered inducements for their enhanced participation in clinical research with extra points toward their star ratings, which are very important to them. Going forward, we should carefully study the lessons from PCORNet and its distributed data network. If we can step back and look at the big picture, we should be able to take advantage of the interrelated and equally important goals of fueling clinical research with data that is simultaneously essential for care management in an industry that has finally become, after many years of saying that the sky is falling, unaffordable to average Americans. Thank you for giving me the opportunity to present, even though it is not in person.